The 11th South African AIDS Conference is meeting in Durban. While the country has made significant strides, it has also recently suffered setbacks and worrying trends concerning some groups, such as the youth. Good evening, welcome to Unfiltered. I'm Mpofu-Walsh. Is COVID-19 the only reason behind these declines? If the strategies are solid, why do we still have 1,300 HIV new weekly infections among young people? Where are the awareness campaigns and how effective are they? Joining us for this studio discussion, we have Ndumiso Madubela, Program Specialist, Adolescents and Young People for the Networking HIV/AIDS Community of Southern Africa, Musa Mbewe, an HIV/AIDS activist, and via Zoom, we are joined by Professor Francois Venter, Professor of Medicine at WITS, and Dr. Tato Chidarikire, Acting Chief Director for HIV/AIDS Prevention Strategies from the National Department of Health. Before we embark on our discussion, let's have a look at this scene setter.
We demand an AIDS-free generation, and that is non-negotiable.
A spirited plea as close to 2,000 delegates gather in Durban to discuss progress and challenges in curbing the HIV pandemic, 4 years after the meeting was interrupted by the COVID-19 pandemic. South Africa has come a long way since the disease was first reported in 1982 and the first death announced in 1985. Collaborative efforts have been made by public and public stakeholders to confront the epidemic, fueled by strong civil society through policy changes, increased funding and advances in scientific research. This resulted in steep declines in infection and death rates, but since the onset of COVID-19, there are concerns that this progress has been reversed and more still needs to be done.
The curves are simply not bending fast enough to stop the pandemic. Last year, approximately 200,000 South Africans became newly infected and 51,000 died from AIDS-related illnesses.
In October last year, UNAIDS raised alarm about the increase in new HIV infections in a number of countries. It said there were 1.5 million new HIV infections in 2021, 1 million higher than the 2020 target of 500,000. In South Africa, the most concerning group are young people, with statistics showing that new infection rates between the ages of 15 to 24 are 1,300 every week.
Youth-friendly services are available in clinics, and we are here to just say, young people, go out there and access your services.
We teach people about how easily contractable HIV is and what are the means of probably getting services like PrEP for the youth and things like consent.
To those that are HIV negative, I want to assure them that they should always keep in mind that their health comes first as well. They should take their PrEP, they should condomize and make sure that they are living a healthy life.
South Africa has the largest HIV epidemic in the world, with close to 8 million South Africans living with the disease, and it has the largest HIV treatment program in the world. The United Nations Sustainable Development Goals calls for member states to end HIV by 2030. Can South Africa achieve these goals? For Unfiltered, I'm Nonoma Gongoma.
Welcome back and welcome again to my panel. Ms. Mbewe, we often have conversations about HIV and AIDS in South Africa in the abstract, but this is a deeply personal journey for many people in South Africa.
Yes.
Your personal journey has informed your incredible work and activism. Could you share some of how your own personal story has led to your important work in the activist space around HIV and AIDS in South Africa?
Yes, Cesar, I'll do so. I think it's important for me to give you a brief background as to why I'm sitting on this chair, qualified to be talking about HIV and AIDS. My story, I got infected after I was gang raped, and I was a regular person who was going to the doctor all the time. I knew my bloods. I was a blood donor and that. And I was gang raped. It was a very brutal gang rape that I was left there. They went to dump me after that because they thought I was dead already. It was 4 guys. And at that time, HIV was not even known. When it was introduced, it was only AIDS. So there were even songs that were made about it. The stigma was rife. People wouldn't touch you at that time. That was 1998. And after the incident that happened, I had to deal with the recovery, which was another year in hospital. Not okay. My organs failing. I didn't understand what was happening. There was treatment that was there at that time. I remember how they introduced it to me. They said, if you take this one tablet, you can live up to 10 years. And that was the time I was given as a cap. That's how long I'm going to live. And I'm looking at this, I'm thinking, oh my God, how am I supposed to live 10 years? My daughter I was breastfeeding at the time when it happened. And now I must count when my daughter is 10 years, I'll be dead. And I thought, and they were telling me, preparing me that when you drink the medication, it's going to disform you, but at least you can live. But if you don't take it, then you're just going to die, and that's it. And I was looking at this. I'm going to be raped. I'm going to be left for dead. I'm going to die in 10 years. I'm supposed to be disfigured by this medication that made everybody look the same. In fact, everyone who started taking medication at that time, they all looked alike. You'll have big bust, big tummy, and flat at the back, you know, even if you're a female. So everything was telling the world that this is what you've got. At that time, I'm not even ready to share with my family or anyone. This is what is happening to me. Because even my mom, you know, sometimes people will be talking and say, you know, even that one has got this thing. I had to keep the secret and struggle with the medication that wasn't working for me. And I decided I'm not going to take this medication. I made a decision. If this is what I'm dealing with, God is supposed to still make me. I need to understand why I had to go through that situation. Why do I have to go through all this pain? And now I'm supposed to be taking a medication that adds to my trauma and all those things. I said, no ways, I'm not going to take it. For 14 years, I stayed without medication until my body couldn't take it anymore. It literally couldn't. I didn't just get sick. I was full blown with AIDS. That I never got to introduce myself. This is me. I'm taking medication. Everybody knew, even the neighbors. People were having conversation about when am I going to be buried, because now they see that I'm sick. I think I'll just fast forward after that, when I decided, because at that point I knew there is nothing else I can do. I must try this medication. This is how my doctor tried to motivate me. You know what? Take this medication, you'll keep your bums now. This one is better. Because at least I wanted to keep something. You know, I didn't want to be, it's not like I had it big. But yeah, I tried. And the medication at that time as well, which was now 14 years later, it was giving me this nightmares that you would be sleeping and you're thinking there's things, you know, you just couldn't cope. I went to the doctors and I was like saying to them, but this medication is giving me nightmares, I can't sleep. Before I could tell him, the doctor said to me, oh, you're also getting nightmares. I'm like, really? So you know about these nightmares. and then you do, no, it's initiation. You're only going to take it for a month and you're going to be okay. I said, nonsense, I'm not going to do this thing. I stopped medication. And that's how I started killing myself, because I'd already introduced the drug in my system. And now even the way I was sick got even worse. Everything was wrong, literally my organs. Like that I ended up at a point where they cut half of my intestines out, because everything was damaged. I had shingles, you name them, everything. I got full blown. So it has been a very bad experience. But the thought of saying, I'm taking this medication for my life of something I didn't invite. I'm not saying there's a better way of contracting that, but especially if you have been raped, which is a number of young people today who are actually living with this thing from the trauma of dealing with the situation. And I think that's just one of the things. I'm sure this covers, just to give you the background as to, and that's how I then decided I'm going to be active about this. I'm going to make sure if there is a grave we can rob, I will do it. That's just how now I am in this work of advocating and saying, guys, we can still live and make it. But there's a number of things also happening.
Thank you for sharing that, Shang. Thank you for sharing the way that your story has shaped your own activism. And I think it's just so important and powerful for us to hear those personal stories of grappling with the difficulty of this virus and how it affects so many people. And we really appreciate your power in sharing your story. And you now are an activist.
Yes.
And tell us about the activism and how you've seen the activist role in terms of your life and your work within public awareness for HIV and AIDS?
It's the importance of activism that works even better. Because when you are not preaching to people what you read, which is the mistake that is happening most times, that we've got doctors that will tell us about these beautiful things, and I'm not saying it's wrong, but they don't know what we're going through. When you are talking from the journey of understanding what is happening, you can take a person through. There's a number of things that are happening that I've experienced. I had to teach doctors as to how to deal with me because they didn't understand. I would tell them that you are reading it in the book, I'm living it. And I would tell them there's a time where I did wrong things, like I stopped taking medication because of the side effects that I was getting. But that's in knowledge that is not out there to make people understand that you will get those things. How do you go past it? I mean, we're talking about one drug that is supposed to be one size fit all. And as beautiful as it can be, it's not always going to be the case. The side effects that I'm dealing with are saying to me, choose. You're going to live with the side effects because if you stop this medication is going to kill you. Ask me how bad the side effects are. They're extremely bad. And the medication is just universal in that. So those are all those things. How do we get to treatment fatigue? You're 16 years. You are raped or you contracted HIV without being raped. You're supposed to take this on a daily basis until you die, whenever you're going to be. There's those terms of all those things that we need to explain to them, because I did as well. I was fatigued. I remember the other day I was asked, please go back to the medication. And immediately when I pulled off, I could tell my body, the side effects were gone, but the sickness was killing me inside and all those things. So, and then there's also religion that tells you, God, you can just pray, God will heal you. And you're going to, so all those things that are voices that are coming through to you dealing with the situation of being stigmatized, because the stigma is still there. It's very rife. And that's one of the things. So I think what we're supposed to be coming out with today is how to help those people, because they are dealing with the real problems. There is not a single person out there who is sick and all they want to do is to torture themselves until they die. No, something is not working in the system that we've got.
Professor Venter, we've heard a personal journey, also a journey of activism, but of course there are important aspects of still disinformation about treatment, about the importance of treatment. Take us through, just from the medical perspective, the absolute crucial importance of consistency of treatment and some of the experiences that you've had from your interesting academic and medical perspective.
Sure, and it's important to understand the country's been on a bit of a journey in terms of perfecting its program, and it's not perfect, but it's come through a lot of steps that have improved it, and Tato can talk to it as well. We started the MASS program in 2004, and South Africa is the largest by far, in the world. And when we started in 2004, we had the drugs, and you heard talked about the side effects and the kind of swelling and the fat distribution. Those drugs we managed to replace in 2010 and come up with a drug cocktail which was substantially safer. And then in 2019, 2020, it shifted across to a new combination that actually replaced some of those sleep disorders and things that you heard described, which terrified a substantial minority of patients. And, at the moment, we're sitting with a program where the drugs to diagnose HIV, to monitor HIV, drugs to prevent HIV, and now to treat HIV are probably the same drugs you get in New York, in Brisbane, in London, you get in Johannesburg, in Cape Town, in Piet Retief. And this is the remarkable thing about the South African program. You talked about the challenges of who's not getting the drugs. It's not about the diagnostics. It's not about the blood tests. It's not about the drugs anymore. It's about the systems that are failing to be friendly enough, to be accessible enough around that. We've solved a lot of over the last 20 years, the issues around, how to make the various tests and things and the side effects better. There's still occasional patients who are still getting side effects, and there's always room for improvement. But we've come a long, long way there. And now for somebody to be having side effects is unacceptable. For somebody not to get diagnosed is unacceptable. For somebody not to have access to prevention is unacceptable in the South African program. And there are harsh questions to be asked for why the system is not delivering on that. When the resources are there, the drugs are there, the blood tests are there. And I think that is important for the country to be asking.
Absolutely. Dr. Chidagire, you sit at the center of South Africa's efforts to mobilize around HIV and AIDS. What's your assessment of where we currently stand? And to Professor Venter's point, do you think that we are in some ways falling behind and backsliding on our ability to meet our ambitious goals for HIV and AIDS in South Africa?
So if one were to talk about maybe, let me use backsliding as the word that you used, one would actually take us back to 2 years ago, when actually the gains that we had made, even in the previous years, were actually in a way reversed because of the lockdowns of the COVID pandemic. Within the department, yes, we do have policies, we have supply chain processes. All of these were, or rather at least the supply chain processes, were actually affected. I don't want to take us back to many years ago, but just from, like, let's say COVID-19 up to now, where we are today. And then if I take us back to our policies, right now, what we're trying to do is to use what we call differentiated models of care or differentiated service delivery, where we're trying to take services to the people to make sure that,
did COVID, can you explain how COVID actually did have an impact? Because that's quite interesting. In what ways did it have an impact on HIV and AIDS?
Oh, one may remember that at this point, I'll talk about the first quarter, like the first financial year quarter, April, May, June of 2020, when we had the hard lockdowns. Even though one would say that clinics were left as essential services, but the point is, especially in April, when the first hard lockdown rules and regulations were in place, one couldn't even get to a clinic because we're not even allowed to be on the streets. One couldn't take a taxi. A lot of our patients use public transport to get to clinics. So that in itself was actually a little bit of a challenge that actually, I mean, it's fair to acknowledge this because it did happen and it has been acknowledged on many platforms. It wasn't, access became a challenge. And even when one would be in a facility, you know, when a nurse got infected by COVID, then the clinic gets locked down and it gets, there was sanitation, because at the time we didn't understand what was happening. So a lot of the services, especially HIV services, really were affected. And one would say that COVID just about reversed whatever gains that we had made in the past few years.
Could we leave it there for now? We'll come back on some of those questions and also speak to Mr. Madubela about some of his important research working with young men. We're going to deepen our conversation on HIV and AIDS in South Africa with the 11th National AIDS Conference underway. We'll be back after the break. Don't go anywhere. Welcome back to Unfiltered. Mr. Madubela, you do important work and research, particularly looking at young men, but also just young people in South Africa. The infection rates are still worryingly high. Yeah. Of course, one needs to say we've made massive progress, especially over the last 2 decades or so. But what in your work and through your insights have you seen is behind some of these continued infection rates?
Yeah, I mean, I think, Sizwe, you're very right that as a global community and as a country, South Africa, as much as we're still the epicenter of HIV and AIDS, we've done tremendous work and we've done really, really important work, but we still have a long way to go. And I think part of the thing, especially looking at the conference that was being held in Durban now, there really ought to be a focus on community. We need to refocus and re-engage at community level because, I mean, I think as my colleagues have spoken now around, there's still stigma on HIV and AIDS in this country. And as you say now, the people that are affected by HIV and AIDS the most, which is adolescents and young people, are not aware of their risk or are not. We need to make sure that they're accessing healthcare services, that they can get the services to help them, to help them stay HIV negative if they're HIV negative, and if they are HIV positive, to help them be on treatment. So one of the organization that I work for is called NACOSA, and so we work alongside donors, we work alongside government, and of course research institutions to and as well as community organizations. And that's where I really want to focus on, because I think when we go back there, take it back to the community, because then when we talk about stigma and we get to a point where we start normalizing and being able to talk about HIV and AIDS, till this day, if you in any family table, if you talk about HIV and AIDS in South Africa, it's a very taboo topic, which it does not make sense. So I think there's a lot of efforts that's needed towards re-engaging at community level. And so what we do as NACOSA is we mobilize resources. We work with community organizations at implementing programs specifically for HIV prevention and for adherence and support for people living with HIV and AIDS, and of course wanting to stop TB as well as gender-based violence in communities. Absolutely.
I'd like to move on to where South Africa currently stands, because we've got this 95, 95, 95 target. 95% of people knowing their status. Then of those people who know their status, 95% of those should be on treatment. And of those, 95% should be able to have viral suppression through taking that treatment. And so we seem to be struggling with the second and third of those. And what, in your respective views, is behind our failure to get that taking of treatment once you know your status up from around the high 70s to the high 90s where we need it to be. Let me start with you, and then we'll go through the panel on that.
Yeah, I mean, I think we have a lot to learn from our neighbors, Botswana, who have achieved these goals. So we know that we can end HIV. This is not some dream that is unattainable. It is possible. We can achieve those goals. And again, I think I'll go back to what I was saying earlier, in that we need to refocus on community at community level. I think my colleague now was just talking about fatigue and taking pills, taking pill fatigue, right?
Yeah.
There's no support at community level. I think one of the things that we really need to focus on is how do we demedicalize taking pills? And how do we demedicalize just accessing healthcare services?
What would demedicalizing mean?
So I think one of the important work that we're doing is having mobile services and mobile clinics go into communities. So instead of saying young people, especially given that they are at risk, come to us, these are our healthcare facilities. Let's actually go to communities, have those in spaces that young people frequent, have those in, there's something called, for example, a pre-exposure prophylaxis, which is a technology that prevents you from getting HIV. If you're taking it consistently, it's been shown to be efficacious to that if you come into contraction with HIV, you don't get it. So now young people don't know about this. And this is a free and accessible technology that should be available to absolutely anyone and everyone. So I think, for me, it's how do we re-engage at community level? How do we have community strengthening systems? How do we mobilize at community level and make sure that this is something we normalize it and trying to destigmatize HIV?
Absolutely. Dr. Chidarikire, what's your view on that second 95% goal and making sure that those who know their status are actually making use of the treatments that are available?
Right. So I will be responding to the second 95 you said. So the second 95 is initiation, right? Making sure that 95% of those who have been diagnosed positive are actually initiated on treatment.
Yeah.
So what we have done to try and support clients or patients to be initiated on treatment is that the policies, at the test and treat, we are now offering test and treat such that one gets tested and then they can actually be offered treatment as soon as possible within the shortest possible time. That's one of the ways that we want to ensure that we don't lose clients within the cascade of treatment. And then one would then also talk about, I think my colleague who just spoke now talked about, well, he used the word demedicalized. Earlier, I used the word differentiated services, and that's bringing services to the communities. And that's where we also agree that we need to make sure that we bring services into the communities. We create an enabling environment that enables everyone to be able to access that treatment, because dynamics are different, within provinces, within districts, even to the smallest area like a ward. Dynamics would be different. There'll be structural issues where one may not go to a clinic to get that treatment simply because they don't have money to get into a taxi. Or he also mentioned treatment fatigue, support, the lack of support on adherence. And then we also have issues of patients of going into a facility. And then for many different reasons that we have had a lot of reports from our community-led monitoring partners that even within the clinic itself, it's not so enabling. One can go and there's a lot of attitude, there's a lot of bad treatment, prejudice. We talk about stigma, which is still right. We can't undermine stigma at this point. So there are a lot of challenges that are actually affecting or even in making people not to even want to get initiated, let alone to stay on treatment. So what we're trying to do is to ensure that we provide services that are actually enabling to clients. We are, I would say, training and mentoring public health facilities to ensure that they do not, they stop discriminating or treating patients with prejudice or having attitude. Those are some of the ways that we are trying to ensure that clients actually do come through. And then also, we have a fixed dose regimen, which is a lot better than many years ago when we had many pills that one would have to take at a time. And then again, to try and stay on treatment, we offer multi-month, dispensing, where one could get 2 to 3 months of treatment so that they don't have to go back into a facility over and over and over, as long as they are stable.
Professor Venter, your perspectives on this middle 95%, as it were, those who know their status and are still not accessing treatment consistently or at all?
I think it's important to acknowledge that we're dealing with a hard problem. Most countries in the world are grappling with the second 95. There are very few countries that have cracked it, and they tend to be quite small countries in a very contained geographic region, or countries like Botswana, which is essentially 2 towns. South Africa is a sprawling with population in very different areas, and I think that we do need to acknowledge it's going to be hard. The other thing to acknowledge is that South Africa is essentially 2 countries when it comes to the second 95, which is men and women. Women pretty much are at 95 already. Men are a disaster. And once you start breaking it down like that, and then also when you look at men and women, young people are a bit of a disaster. They tend to come in very, very late. And that allows us to start focusing our energies as to what we need to start addressing, and perhaps we need to be thinking about more creative options for those groups of people. I don't have any easy solutions for that, but it's the same problem Brazil's facing. It's the same problem the United States is facing in terms of its HIV response. And I think South Africa is going to have to grapple with things. You can't simply open your clinic doors and hope that men and young people are going to flock. You're going to have to do something differently.
No, absolutely. I think those insights themselves are interesting. And Ms. Mbewe, in terms of your community work and community activism, what are you seeing in terms of those who know their status but are still not accessing the treatment? What are some of the barriers and what are some of the challenges there?
Let's deal with the reality of it, being our government and the system. If we've got all these things that are put together to try and make sure we don't have this topic today, and they are still happening, someone is sleeping on their job. There is not proper monitoring. For instance, we should not still be talking about public health care, having health workers who are rude to the patients and treat them as their own, and the government knows and it does nothing. That's not going to work. Number 2, we can't deal with an HIV story without dealing with the real core that multiplies and gets us to this point, without dealing with the youth not being employed and not having income in the homesteads where these children stay there and they decide, the young ones, maybe not just children, the young ones decide to do other things because the system is also not working. So everything that we are doing becomes just the tip of an iceberg because we're not really looking at the core. I will go back to exactly what I said before. Not a single person who wants to be alive will be diagnosed and decide they don't take treatment. But where are we dropping the ball? And then the other thing is that we've got all these systems. What they are concentrating on is statistics. I know that. I'm part of the things. They are talking statistics. Now, statistics is what is written there. It's very far to the reality of the people that we are helping. Now, we're going to be having these big conferences and spending so much money of the government, which can be utilized to be dealing with with the real core of what is happening, what makes this. There's people who can't go to the clinic because they can't afford. You go to the clinic and they will tell you the medication is not there, go to the next clinic. How do you go there? What is happening at home? And all those things. The reality of that, we've got systems in place, but those systems are just good in looking because someone is not doing what they should be doing. Where is the monitoring? Why are we still talking about obvious things that should not even exist? Why are we supposed to be asking health workers who have signed to be there and they say an oath? Everything is just acting. We must stop acting now and get to the reality and make sure that the systems are working to benefit and save our children so that our young ones can have a long life. That's where the real problem and the core is from what I am dealing with.
Absolutely, and I'll invite some of the other guests to respond to that perspective. We're in conversation with a fascinating panel of activists, academics, government leaders, as we discuss South Africa and HIV and AIDS in light of the 11th National AIDS Conference that's been happening in Durban. We're going to come back and discuss some of these questions about the deeper social crises and economic crises in our country and how they come to bear on public health. Don't go anywhere. See you after the break. Welcome back to Unfiltered. We left by asking how in South Africa's strategy to combat HIV and AIDS, we could address that middle 95% of our global goals, which is those people who know their status. How can we get consistent treatment to those people and make sure that once you know your status, you're also accessing the treatment that can be life-saving and life-affirming. We were discussing the extent to which the state is at fault for our failure to reach that 95% goal. Dr. Chidarikire, we have a plan that we are rolling out to try and meet our goals. To what extent do you think this plan is being implemented and is being achieved? And to what extent do you think that government is simply failing to do the basics as has been suggested to implement this plan? Because yes, there are hard problems, but it also seems like there are some easy problems that we still haven't seen government actually turning around.
So if we talk about the country's response to HIV and AIDS, we are talking about the National Strategic Plan. We know that we now have a new one that was just approved in March during the World TB Day. And that's the fifth generation NSP that will take us to our 2030 agenda. However, if I were to take us to maybe a smaller plan where we are trying to operationalize the strategic issues that are coming through the strategic plans to ensure that we reach the second and the third 90, we have an approach that we have termed a NEV center approach or 100 facilities type of approach, where we have identified 100 facilities in 17 districts in the country, and we are actually hitting on those facilities because one of the inclusion criteria for those was that they have not reached, their patients in those facilities have not reached at a minimum 80%, the second 95. And if these facilities do not reach even 80% of their second 95, it means that we're going to struggle for a very long time and probably not even get to where we are trying to get to, which is just over 2025 and towards the 2030 goal. And what we're doing here is that from national, we're working with the provinces and districts and working with our implementing partners to ensure that we now try to go and figure out what is wrong. We have community-led monitoring organizations that are working to find out what are the challenges that are making patients not go back to clinics or not take that treatment. And that's where we want to try and hit and try and figure out why is it that this particular facility or this community has so many people that are not going to take that treatment or that are falling off even if they had started. Because this second 95 while it's about initiation, it also is about ensuring that people that we have initiated are then moved into, the viral suppression, which is the third 95, which is actually quite critical to keep people there. So I don't know if I would want to say that people are not doing that job per se, but we acknowledge the challenges. We acknowledge that there are gaps. And that is why it is myself who actually mentioned issues of stigma, issues of prejudice, because it is there. It would be unfair not to mention such, because it has been, reported. And we are really making sure that we're trying to work on that. And the fact that we are operationalizing this now means that we are trying to focus. Because really, if you want to make an impact, you have to focus where there are major problems. And within these 100 facilities, that we are trying to ensure that they get to their second 95, because the first 95 is not so much of the problem. But if we can get to the second 95, then we'll be able to move into the third 95. And this is an operational plan that we are trying to implement to get there, using, utilizing or working together with the civil society sectors, with the provinces, with the partners, with the overarching support of SANAC as well, and the National Department of Health. Thank you.
Professor Venter, can you take us through the importance of viral suppression, this third important plank of the 95-95-95 strategy? So first, knowing your status being the first, and as we've said, the second. Once you know your status, consistent initiation of treatment. But then the third is this question of viral suppression. What is the importance of that and the significance of that in our wider strategy?
So just to walk people through, you'll take a tablet every day. The tablet that is a combination of 3 drugs, which we now know are very safe. You usually will have a few side effects for a couple of days, if you're unlucky, a week or two. And if you're very, very unlucky, side effects that will take a month or so. And they tend to be quite mild. They might disturb your sleep a bit. You might feel a little bit nauseous at worst. And then it settles down. Your virus disappears from your bloodstream, and usually within a few weeks, you become non-infectious. You do not transmit the virus onwards, which is a remarkable thing. You just essentially, this U equals U message we talk about, undetectable equals uninfectious. And that's a really powerful message, is the fact that you now have been returned to essentially becoming HIV negative. It also allows your immune system to start rapidly returning back to normal. And there's data presented at this conference, and there's been data previously done by a whole lot of really smart people at UCT, demonstrating that people who start their ARVs, particularly at an early stage, start returning to a near normal lifespan. So you get back to normal is the short message. You can get on with your life. It doesn't mean the stigma issues are not there. It doesn't mean the annoyance of having to go back to clinic and swallowing a tablet every day. But we really have made a remarkable step forward with this to get people as close to as damaged to living a normal life.
Absolutely. Mr. Madubela, any thoughts on what some of the panelists have already said so far?
Yeah, no, definitely. I think I concur. And I think it's very important that we acknowledge that we're dealing with a very complex problem. And so it would be really, really valuable to divorce this idea that the solution is going to be a linear and simplistic solution. It's a complex problem that needs complex solutions and creative solutions in doing that. And so I think even before the break, one of the things we were talking about is just having dialogue and having spaces like this so we can continuously, destigmatize and normalize having conversations around HIV and AIDS. And of course, when you're talking about government and healthcare systems, I wouldn't say we should just blame government. I think this is a solution that we should all participate in trying to get to our goals. This is not a government problem only. It's not a business problem only. It's not a community organizations problem only. It's everyone, right? Everyone needs to come to the party and play their part and participate. And I think if we do that, we will go in the trend that we're going right now and actually achieve our goals, or come very close at least.
Absolutely. Ms. Mbewe, your views
on the third 95?
On the third 95, and anything in this conversation that you'd like to highlight?
I strongly believe it's something that we can beat and we can win if we work together. I will keep on using the word being real. about the things that are happening. That is going to assist us a lot. Of course, it will never be just one-handed, but where we can, I like the way you're saying, let's deal with the quick wins. We've got quick wins. If we can really come to a point of making our health system user-friendly and a place that a person looks at as a safe haven than I still get those things when I have to go to the clinic. Fortunately enough, there's systems that can be standardized. Maybe I should just mention that because it all lies from there. Are people going there to get their medication and that? Maybe I can mention this. It's a government health facility in Helen Joseph. They will send you a message 2 weeks before. Your next appointment is going to be on this day. That's beautiful. A day before, remember, tomorrow you've got a visit. After you went to get, it's a public health. After you went to get your medication, they will say, thank you for coming to the clinic. If you didn't come, those things, because the first thing we need to do people who want to cure or help us care about us? If we can deal with the care part of things, I promise you the rest is history, because that for me is love and it makes me feel very respected. And even if we have missed, if we can do those small things, we will see that the rest of the other things are just getting easier. And then we can work together and make those who get to be infected whilst they're young to tell them that you can leave. And the stigma issue around that, it's also very important, because people still, even me, I can't be, hi, I'm Musambe, I'm HIV positive. That's not how, can I be a human being, and all those things. And then there's issues around disclosure that I suppose, where a person feels guilty of not disclosing their status. If something happens, I meet a guy because I know I'm HIV positive. I don't know if the person is HIV positive. I will be blamed because people know, but I don't know his status. So there's all those conversations we're supposed to be having. Does this young person who wants to be in a relationship with a healthy person wants to disclose that? Because those things also are those discussions. Are we having enough discussions that makes people comfortable? Because really at the point where we are, with everything that has been done, I'm not closing it and say it's not working. There's a number of things that have been done, but we can make it easier and make it something that comes home where people are really relaxed about the subject, because that's where it is. It's not taking medication. It's the subject is not comfortable. Let's make the subject comfortable by making sure that all the stakeholders in this are helping us to do this. So we don't just go for the conference to hear how it has increased in 2023. It's doable, I believe.
Yeah, absolutely. Can South Africa end the HIV and AIDS epidemic by 2030? That's the ambitious goal that's been set. And if we put our minds to it, it may well be achievable. When we come back, we'll take some thoughts from social media as well as think through some further and more immediate solutions. Don't go anywhere and join us after the break as we wrap up our conversation. Welcome back to Unfiltered as we wrap up our conversation. We were speaking earlier about, statistically, it looks like the middle 95, that is people who know their status and not consistently accessing treatment being a problem. But we shouldn't assume that people are testing, that people are, at the maximum knowing their status, taking preventative measures. So perhaps we can speak about that earlier phase of prevention and also awareness and knowing one's own status and making sure that we're still, up to speed on that, because that's where it all cascades from.
I think so. My views, and again, sticking very aligned to some of the work that we're doing, working with adolescent and young people, is those are the populations, or those are the group of people that are most at risk of contracting HIV, as the statistics say. So why aren't we normalizing having access to healthcare services for young people? Let's have self-testing to these populations because they need it the most. Let's make sure that each and every single young person in this country, because we know, for example, statistically, the sexual debut in this country is on average 12 to 14 years old. Right? So the reality is young people are having sex out there. So I think gone are the days we really should divorce this idea that, okay, we will help them when we talk to a young person when they're 18 or whenever. No, young people are having sex. The statistics are there, they'll tell you. So let's have these engagements, one, all year round. let's normalize HIV and talking about so that we can destigmatize it. Let's refocus, like I said earlier, at community level and have, well, we'll call it, whether it's differentiated service delivery to these people. Let the clinic not be the only way for me to access my medication if I want medication. Let's have more mobile clinics. Let's have more investments and dialogue in terms of what you're saying now, that I'm not more than just a number.
Yeah.
I'm more than just a statistic. This is someone's life.
Yes.
And of course, let's keep young people HIV negative as much as we possibly can. Let's talk about technologies and interventions like PrEP, which is pre-exposure prophylaxis, right? I feel like these are not commonly known. And that's, I think, part of the problems that we really still need to focus and work on.
Absolutely. One of the things that concerns me, all members of the panel, is it feels like disinformation around HIV and AIDS is back on the rise. Unlike maybe 20 years ago, we now have this new social media disinformation to contend with. And I'd like to show you some of the things coming up from social media and just some of the things that I've seen. And it's quite concerning to me that there's this new rise in disinformation. So, we see comments like these where COVID vaccine got new AIDS in it. Kim says, not if we cease receiving US subsidized antiretrovirals. So there's this worrying attempt to delegitimize treatments that we know work, to undermine the science on this. And the social media age is not doing us any favors. But perhaps, Professor Venter, you may want to weigh in here, and I'll take some views as we close from our other panelists in terms of this disinformation age and how it bears on HIV and AIDS in South Africa.
We need to take it seriously. I thought we'd seen the tail end of the anti-AIDS people 10 years ago, 15 years ago, and they are back again. Not in the same numbers, but there's this unholy alliance with the COVID denialists and this very strange group of people. And I think it'd be silly to not take it seriously. We're seeing plunging vaccine numbers, which is very worrying. We're seeing the rise of things like measles on the back of this across the globe, and it's really rolling back things would be a tragedy. I don't think people understand how close we are. More successful than I've been doing this for 20 years. We're more successful than my wildest dreams in terms of how we've done with the ARV program. And now with the prevention program, we've seen the numbers coming down. We're not going to hit the targets, the ambitious targets we've set for 2030, but we're close. And if we rededicate ourselves and we refocus, there's a chance we can sort it out. If we sort that second 95 out, there's a chance we can get there. And to be distracted by this kind of disinformation would be an absolute tragedy. We've got these new technologies on the rise in the next 2 or 3 years that allows, particularly to protect young women. It's really important that we guard those gains we've made and try and finish the job, over the next couple of years, where we actually do get to the point where we control this virus in this country and make it into so we can concentrate on all the other challenges we have in the health system.
Absolutely. Dr. Chidarikire, are you seeing the rise of disinformation as a challenge to your plans and strategies as you embark on a new national strategic plan?
If left, if left to run on its own, it will eventually cause problems, because we don't want to have this kind of information running on its own. So as Prof says, we need to take it seriously. And I would say if it's coming through digital platforms, we use the very same digital platforms to debunk the myths, to respond to such, to ensure that we pass information, especially with our young people who are actually allowed to use digital media and will get this information from the very same platforms that they use for a whole lot of other things that they use. So it will be very important to catch it at the very same drive where it is and make sure that we totally debunk and demyth so that we don't have these challenges in the future.
Absolutely. Ms. Mbewe, you were also speaking about, in your activism, in the work that you do, contending with misinformation or people not knowing the effects and the positive impacts You've also spoken about how difficult it can be to be on treatment, and we shouldn't overlook that.
Yes.
But that's not to say that treatment is not important. And,
Yes,
and
of
can you tell us, some of the things that you've seen in some of the misconceptions that you have to deal with, and how do you actually deal with those on a community level, on a one-to-one level with the people that you work with?
It gets to be a little easy for me because I've done it all. As I said, I'm the one. I stopped medication more than twice, and on all those occasions, even when I was told, I used this thing that I'm a believer, I'm a child of God. That when you pray, you can pray, God, I've prayed for you, I'm healed, and all those things. I did it. I believed.
A big thing. Religious misconceptions. People using religion to try and
and I'm taking it there because that's it's a trap that I fell into. And when I stopped the medication, I nearly died, and I looked at that. Do I really, after everything that I've done, want to do that? The treatment is very important, and what we are going to get at, even when, because I see this media, if we keep emphasizing on what we're supposed to be doing, which is we're doing it in the right way, this is going to die. Assuming this person is saying whatever, if COVID has introduced it, as fake as the news are, when you've got it, we are still saying come and take the treatment and use the medication so that you don't die anyway, because that's what we are trying to do, to make sure that we are protecting you. But also, if we emphasize on the communication we send out there, that is helping. It dies down. There will always be negative things that are happening. It has been happening for a long time. It is concerning. It's not going to scare us much as long as we do the right thing, because all we are saying at the end of the day, with all these things that are said, we want you alive. We want you safe. Take the treatment and keep alive for as long as possible. I think that's very important to say that. And then we will then assist in making sure it's easy for you to take treatment. I've tried it more than once. I made a vow that I'm not going to take this thing for the rest of my life. When that's how many years now, so 24 years. And I was like, there's no way I'm going to take this thing until I die. At some point, I'm going to stop. I'm sitting here, I'm singing a new tune because I'm full-bodied, I'm healthy. And until I tell you, you won't know that I'm not okay. So we're going to keep doing the right things just to make sure that we also use that to erase what is out there. Because treatment is very important. The young ones, when you get it, even if you don't tell, because there's another thing that I really want to quickly get at, that they will say, if I take medication, people will see that I'm sick. I always say to them, if you take medication, people won't know that you are sick, because you can hide it. It's just one tablet. You can go and hide and no one is going to get to know. So I've got a lot of cases like that where I had to deal with young ones who couldn't take because they thought they're going. I said it's easy. You can put it in a tissue, wherever. I can put mine in the panado box. We used all those things to say, just keep alive. If you take it now, that you know now, you're not going to be sick. So no one is going to get to know. So you don't owe anyone an explanation. Also, to even divulge or tell them about your status. If we do what we said, that don't make it to only be at the clinic. So that if you want to keep it to yourself, you keep alive. We are going to get to the last 95.
Absolutely. Just to thank all of you for the work that you do. I think this is in some ways one of the few success stories of South Africa, maybe in the last 2 decades, which perhaps we don't trumpet enough, but at the same time also for reminding us that this success is not for the taking. We still need to make sure that we put our foot to the pedal and see our way through to 95, 95, and 95. And that can only be done through dialogue, conversation like this, and the important work that you all do. So thank you very much for joining our panel this evening and for your insights and your provocations. Thank you so much for joining us again on Unfiltered. I hope this show has given you some insight into not only the ways that you can know your status, the ways that you can access treatment once you know that status, and also the way that you can achieve viral suppression once you access treatment, but also that we've heard personal stories, we've heard activist stories, we've heard academic and government stories, and that we can, as a nation, get to this important milestone of overcoming and ending HIV/AIDS in our country. Look forward to you joining us on the next installment of Unfiltered. Thank you for joining us tonight. We'll continue the conversation on social media. Have a good evening.